Good morning. I've got the daunting task of talking in the next 15 minutes about novel therapeutics for mesothelioma. I'm not going to talk about immunotherapy. I'll start that with that point and focus really on just a few areas given the sort of time limitations. So I think it's important to say a little bit about mesothelioma in the genomic era. We're seeing a total paradigm shift in how we look at cancer and how we're treating certain cancers. And there's no reason why mesothelioma shouldn't be in the same arena. Secondly, talk about a novel approach to targeting cancer networks, particularly where we don't understand the oncogenic processes that are driving proliferation, growth, anti-apoptosis at a mutational level. That's something we heard about yesterday. And so HSP90 is a possible target. And then talking about an approach that we're interested in, which is looking at BRCA1 and the loss of this very important tumor suppressor and how that might be exploited. So I'll spend just a couple of minutes on each of these. It's very clear that if you respond to chemotherapy, you do better, you live longer. We've already published data from meta-analyses of multiple clinical trials in Europe which supports this. The sort of obvious question which arises from these sorts of meta-analyses is how do you then identify responders? And the answer, of course, is to conduct a form of molecular or clinical stratification. This has been working really nicely, actually, in lung cancer. I treat lung cancer, I'm sure many of you do as well. And what's very clear is that over the last 10 years, what we've seen has been a huge paradigm shift in how we treat lung cancer. And the basis for this has been the understanding that this disease is complex, that there is a thing known as inter-patient heterogeneity. Not one tumor from one patient is going to necessarily be identical to another. We have to take that into account when we treat. And so what we're seeing is a sort of increasing branched complexity in how we treat lung cancer. In grey here, you can see over to the right that 10 years ago we started with a sort of a black box approach to treating lung cancer, platinum doublets, which then sort of separated out as we understood about the EGFR mutations. We now have BRAF, ROS, EML4, ALK, chemosensitivity, these variables which we can now explore and use to partition treatment more effectively. When we consider mesothelioma and where we are, of course, this is a very different situation. We're pretty much where we were 12 years ago, really, when the original papers were published around the efficacy of pemetrexed cisplatin. We have an antifolate doublet, and that's it at the moment in terms of licensed systemic therapy. This is what we would term empirical treatment. The idea of the tumor is the black box. We treat it uniformly, doesn't matter who you are, you get the same treatment. This is not how we need to be treating the cancer. And therefore, what I'm going to show you is how we may be able to pull this disease into the targeted era. So looking at lung cancer over the last couple of years, we've had the ICGC, TCGA efforts, which have really shown us this complexity in the somatic mutational landscape, broken the disease up into smaller fragments. Now, with mesothelioma, this is a very different disease. The oncogenesis of this disease is unique. It's asbestos-driven. And what we're seeing is a preponderance of not oncogenic mutations, drivers as we're seeing in lung cancer, but these tumor suppressor mutations. Some of them are extremely common. If you look at the CDKN2A mutation, this occurs over 70% of the time. NF2, somewhere around 50% of the time, compared to the BRAF mutations, the ROS mutations, which may be as low as 1% in certain instances, yet are still fair game for treatment development. So I've got Robert Krantz here, just next door, who, as my co-chair, was involved in some, I think, really important early studies, actually, around this extremely common, low-hanging fruit of a mutation known as CDKN2A. This encodes a tumor suppressor known as P16. Unlike some tumor suppressors like P53, P16 inhibits pretty much one key target, which is CDK4. So it's a very, very common mutation. It may be one of the most important driver mutations within mesothelioma, as we see this in models. We see this in primary tumors. And we know that when you lose P16, you get an increasing aggressiveness in animal models, and you also see a worse prognosis with loss of P16 in patients. So this is an important factor, not only from the possible tumorigenesis of mesothelioma, but also possibly in terms of determining how this tumor behaves. So can we target this gene? Well, yes, potentially. When we talk about oncogenic mutations, we're talking about, in the sense of lung cancer, for example, dependencies. So oncogene addiction can be targeted, for example, by switching off a vital kinase. With CDKN2A and other tumor suppressors, the tumor's already lost the gene because the gene is essentially an anti-cancer gene. But when you lose any gene, you're losing functionality, and that can be exploitable through a process known as synthetic lethality. So some of the early studies that were conducted by Robert and colleagues showed that if you took the gene P16 and you reintroduced it into a context where there was a double loss of each allele of CDKN2A, this was not tolerated. And this forms a type of synthetic lethality. And you can see on the left here, if I go back, can I go back? Yes. This CDKN2A negative model, this has been recapitulated in glioblastoma and other tumors. You can see that there is lethality here, specifically in the CDKN2A mutated tumor, but not in the wild type. And this form of synthetic lethality is potentially exploitable using drug-based therapy because now we have specific CDK4 inhibitors. These are inhibitors that have the potential, perhaps, to phenocopy P16 transfection. And so one of the objectives may be to then look at this approach therapeutically. We know that CDKN2A may occur, may be sort of occurring concurrently with NF2 mutation. And this lovely data, actually, which has shown the effects of having double mutation of NF2, sort of the gene number 2, as we know of at the moment, with CDKN2A, you get very, very aggressive mesotheliomas. So we're taking an approach at the moment to explore a combinatorial strategy where we could potentially target synthetic lethality, two genes, CDKN2A and NF2. And the approach here is actually to use a FAK inhibitor. This is something we'll hear about a little bit later in the day, and also CDKN2A targeting through CDK4/6 inhibition, a phase 1 strategy to then take into a dose escalation. There are ways in which we may, with today's understanding of cancer genomics, try to hypothesize how we might target new mutations. There are mutations, for example, such as SETD2, which we're seeing in mesothelioma. I had a patient who had only SETD2 mutation, nothing else, no CDKN2A, NF2, or anything else. And using something like the genomics of drug sensitivity platform developed by the Sanger Institute and MGH, it's possible to explore drugs which may have hyperactivity under certain genomic contexts. And if you take something like a SETD2 mutation, which I fired into this free portal, you can see that there are drugs which seem to be extremely active in the context of SETD2 mutation. This is increasing sensitivity, and we can see here, is this random? I don't know, probably not. PI3 kinase as the target comes up twice with GSK3 beta. So one might hypothesize that a SETD2 mutation in mesothelioma or any other disease might be amenable to PI3 kinase inhibition. And one can do this for NF2, you can do it for CDKN2A, and indeed, when you do that, some of the appropriate drugs seem to be coming up. We know in lung cancer that the targeting of translocations is extremely important. We now have the ROS, we now have RET, we now have EML4-ALK as a standard therapy target. In mesothelioma, we don't know the full complementation of translocations. We do know about this one. This is EWSR1, which is a transcription factor which is linked now to YY1. And what's interesting, again, is if you fire another, because the breakpoint for this actually is the same, is in common with other genes. FLI1, for example, forms a fusion. You can see sensitivities, interestingly, to gemcitabine. And we know that there's some data showing activity of gemcitabine. This is an active drug in mesothelioma, but we've had quite discordant data actually in phase 2 trials, and that may be due to sampling bias in single-arm phase 2s. But one possibility is if you have enrichment of a translocation positive subset, these patients may do better. We're trying to stratify medicine in non-small cell lung cancer. I think we can try and do that in mesothelioma. And one effort is through the European Consortium of ETOP, EORTC, to look at SPECTR lung. I'm going to rush forward very quickly through the next two sections. We have, within the cancer kinome, many kinases which we know are critical for proliferation, anti-apoptosis, cell growth. Now, what's important to understand is that these kinases do not act alone. In order to fold and to function as an effective kinase, you need to have a chaperone. And a chaperone, like HSP90, is vital for many of these proteins to function. And therefore, we're interested in looking at targeting the chaperone rather than targeting individual kinases so that we can shut down pathways which we think are important for cell growth, for example, AKT, PI3 kinase pathway, and the MAP kinase pathways. Well, this can be achieved clinically, and we've completed a phase 1 trial with Cancer Research UK. The use of an agent known as gantenerumab, which we've shown to have activity in non-small cell lung cancer, is tolerated in combination with frontline treatment, and we're now moving into a randomized phase 2 nationally. We don't have at the present time any way of personalizing this therapy. It's a very pleiotropic target indirectly. You're hitting HSP90, but HSP90 regulates most of the kinome. And so how do you identify biomarkers? We've taken an empirical approach using genome-wide studies, and we've identified subgroups harboring certain CNVs. These are copy number variations, where clearly we're seeing resistance. This is a positive trial, but this subgroup do very, very badly indeed, whereas we can pull out other groups that do very well. So we're hoping to, within mesothelioma, see whether these CNVs have any real meaning. Last 2 slides. BRCA loss is something that we've had a particular interest in. Many of you who treat mesothelioma, particularly in a relapse setting where we have no standard of care, may have been using vinorelbine. And vinorelbine, of course, there is some phase 2 data to suggest that it may be an active drug. We know that it can cause regressions in a small number of patients. But we've been interested in trying to ask, well, can we really target this type of treatment? And one of the ways we may be able to do this is through understanding how it works. Despite the fact that spindle poisons are used so commonly across most solid tumours, we don't really understand how these drugs work, how they induce cell death. We showed a couple of years ago that BRCA1, this important tumour suppressor, is absolutely critical for the apoptosis that's induced by vinorelbine. We also then went on to show that there was a 40% loss of BRCA1 expression in mesothelioma. Accordingly, we've got a trial now which is just about to open. It's a 200-patient randomized study, 2-to-1 randomization, looking at vinorelbine, but critically stratifying patients in the context of BRCA1. And we've shown using functional genetics recently, some published, but we know that there is a complex that's associated with MAD2 transcription that drives a checkpoint and a spindle assembly checkpoint. And it's through that mechanism of regulating spindle assembly checkpoint that BRCA1 seems to coordinate or orchestrate cell death. And so we're looking for other genes which may act in concert with BRCA1, which may be mutated to phenocopy BRCA1 loss. BRCA1 loss, though, doesn't just regulate spindle poison sensitivity, it also regulates, very importantly, DNA repair. And one of the areas that we're quite interested in exploring at the moment, and we're doing this within lung cancer, is looking at the BRCA1 negative phenotype as a predictor for PARP sensitivity. It's been shown many times in the context of breast cancer, for example, that mutation, somatic mutation of BRCA1 is associated with homologous repair deficiency, and this can be exploited using PARP inhibitors. And so we've taken the sort of the model whereby looking in the BRCA1 negative group, where we can see log-fold sensitivity to PARP inhibitors, to explore a trial in which we give PARP inhibition to patients who have this susceptibility to DNA damage. So I'll summarize. We have moved, or we need to move, I should say. We haven't moved there quite yet, although there's some very promising examples, I think. Peter Slozarek, again, has data in this meeting to present. We need to move from an era of empirical therapy to targeted therapy. That's what's happening in melanoma. It's what's happening everywhere else. It's where we're seeing the great successes of targeted therapy. And I think with mesothelioma, we already know what the key candidates are. We just need to action those mutations. And what's really key about these mutations is that they're very, very prevalent. And that prevalence, I think, gives us opportunity. These are low-hanging fruit. I've talked about chaperone dependence, DNA repair pathway deficiencies. There are any number of new opportunities for us. And my hope is that in the next few talks, we'll hear about some of those. So thank you very much indeed for your attention. I'm happy to take questions. I've got 40 seconds left. Thank you.